former, but Leilani was mother to a patient who expired here at Packard due to a medical event. Over the course of time and very quickly, this organization stepped right in, worked with her from the beginning, and her child had been transferred here from a hospital in another state where some of the event preliminarily started there. She has a wonderful TED Talk, and I'll be happy to share the link with anybody, about the difference in handling between the hospital in the other state that chose to take the defend at all costs position and this organization, which went on working with her right from the start and helping her move through that very challenging moment from the time her son expired on to later years. And she now works with us as a liaison to help us develop more of the patient and family perspective to some of the work that we do in claims and litigation. Because you know what? Sometimes we do have a different set of eyes and a way of approaching things. Leilani helps soften that blow for us, and I'd be more than happy to have her give her talk at any other future meeting, and the experience is pretty amazing. Yeah?
I just feel like I'm hearing a little bit of a mixed message. After your last slide, I
Uh-huh.
got the impression that I shouldn't really be contacting risk management until something came up. So I had been subpoenaed or some issue that actually arisen. And this is coming from, I've had lectures with risk management before
Yeah.
from one of the colleagues where they said, call us early. And we always we stabilize the patient and then we call risk management.
Right.
And I find it's usually not very helpful and there's never any follow-up. They actually don't know what's going on.
Okay.
It seems I never hear about it again.
Yeah.
But then, so on the one hand, I'm feeling like I shouldn't contact you unless there's actually a problem there. But now we want to get in there early so that we can help the families through this difficult process. So I
Yeah.
honestly, I don't know what
Okay, no, thank you for bringing that out, and I apologize if I'm creating confusion. What my prior slides were attempting, or thoughts were attempting to communicate is, we don't want to be the first one you call. You've got other individuals who are much better suited to work with you on the immediate patient matter. And we will, early on, I mean, I'm not talking about the minute things happen, but when the dust has settled a little bit, we want to know, because we want to then be able to work with everybody who's managing that event and provide, again, any consultation we can about how to talk to families, what can or can't be done truly in the moment as far as, you know, giving compensation or whatever. We want to be able to remove you all from dealing with the what are you going to do for me now discussions and let us take those over. So the continuum, if we could think of it on a continuum, bad thing happens, there's fallout, to anything before that from a simple question. We're in line on that continuum at any point to be called. It's just at the point when something is really happening and there's critical needs going on. You don't need to call us right then and there. We'll find you. You'll find us, and we'll help manage through that. But again, I'm not talking weeks later. I'm talking not at that moment. Don't be on the phone with me while, you know, there's a code going on. But when the dust settles, then have that discussion. And if it's truly an adverse event, again, we don't want to be the only ones who know about that. You've got attendings, you've got other colleagues who are working with you on that circumstance. And so that's what I meant about we don't want to be the only ones who know. We're a resource to everybody to work with on that. So I hope that, you know what?
I've never, in the situations I've taken, I've been handled all the time. It's never been an adverse situation. So it's a day or two later.
Yeah.
And then
Yeah, here's the worst thing that can happen for all of us, that something goes unmentioned so that we never have an opportunity to work with a patient or a family on resolving or regaining that trust or mitigating the circumstances. And so you be the judge of when it's an appropriate time to call us. Obviously, we'd like it sooner than later because it helps us line up things very quickly. We do lose time and family because at the point in time after something's happening, everybody's in there talking to them. And oddly enough, stories don't always come out the same with families. They hear things differently. Then they say, oh, so-and-so told me this, now what? Now you're telling me that. So again, we like to sometimes be early on in that respect to help gain control with the team and be sort of the quarterbacks to help make that work. Again, no recipe on this. It's really driven by circumstances and what works best for those involved. And then the things that we get called most frequently about really are related to consent issues. My only 2 cents on that is you're in pediatrics. There are some basic rules within the California environment. We love to encourage you to get a grasp on those basic rules because anything more involved or developed off of that will be really an iteration of the basics. So really quickly, in California, anybody under the age of 18 is considered a minor. Therefore, their decision makers are normally somebody else, except in rare circumstances. Those conditions are parent treatment of pregnancy, drug and alcohol treatment, sexual abuse, or anything related to that, and a couple other variations. However, does that mean we don't encourage discussions with 12-year-olds, 13-year-olds, 8-year-olds about the parent treatment that's going on? No, we certainly encourage you to be as forthright and engaging as you can. Also on consent issues, I mentioned earlier, we find that intact families sometimes are not the first point in our relationships with our pediatric patients. We have a lot of families that have a variety of configurations, and we can sometimes help make sense out of that because we know, especially when children are in the hospital, everybody comes out of the woodwork and wants to be helpful and informed, and there are rules around that. Basic rule in California for divorces: when there is a divorce, the presumption is legal custody is shared 50-50. So mom and dad have equal legal custody. Legal custody meaning ability to make decisions, have access to medical records, have care and participation and involvement in the care decisions. Then there's a thing called physical custody. And because you can't slice a kid in half, the child normally resides predominantly with one parent or the other. So legal custody is the rule for decision-making consent issues. The physical custody just happens to be where the kid resides at one point, who has visitation. We care less about that. We do care about the presumption of the 50-50 decision-making in the absence of any paperwork saying to the contrary. And sometimes there will be legal paperwork showing that one parent or the other has 100% legal custody, and then we'll sort through that with you. Disruptive behavior. We have a lot of families and others under a tremendous amount of stress, and sometimes that stress spills out into our environment, creates a little bit of chaos and confusion. Our basic line on that is we are obligated to maintain the safety of our environment first and foremost for our patients and staff, and anybody who's a little sideways to that, not a little because we have pretty big tolerance levels, but extremely sideways on that particular issue, doesn't have an innate right to be here. So if you have family members who are threatening or acting otherwise in a challenging manner, we do have mechanisms. We work closely with our security folks. We call the PAPD. We do work on minimizing the amount of disruption. Event management, we get a lot of questions about handling documentation around certain circumstances or the actual management or handling of adverse events, bill holds, things related to what might minimize the patient-family aggravation. We get a ton of calls from people who have had a request from parents or others who want you to write a letter to help them in a court proceeding of some method. Here's the basic rule on that. You are never obligated, you have no duty to, in fact, comply and write a letter to an attorney or whomever the patient may be requesting or family may be requesting. But there's no prohibition against you doing that or not doing that. Please keep in mind, however, if you are creating documentation outside of the normal course of patient care, meaning to help with a custody or an immigration matter, please know that documentation is subject to further review and scrutiny and challenge, and not that it should dissuade you, but simply writing the letter and providing it doesn't put an end to the situation. You could be called into court, you could be questioned by either side or the side who didn't get the letter about your position and the information in that document. So again, know that the simple act of writing the letter rarely puts an end to the matter and is more done in the spirit of advocacy and less about patient care. So just be a little attuned to that. Again, calls from attorneys. You often will get contacted by attorneys who we all know are trying as well to make their life easy. And if they want information from you or are calling and requesting a call back and it has nothing to do with a matter that we're managing through the risk management office in conjunction with you, you are, again, not obligated to respond to attorneys or provide them with any information. In fact, you may well be precluded without the appropriate authorization. So don't think just because it's an attorney calling you, that means you need to give up any information. And then legal documents related to patient care. We get, again, lots of opportunities here where process servers will be attempting to serve legal papers related to circumstances that have nothing to do with the med center, because you could personally be getting served for a variety of reasons, or have nothing to do with patient care. For example, again, things unrelated like immigration status or whatnot. If you get those documents, again, we'll help you sort through them. We may not be in direct line for handling, but we'll definitely help and advise you. And I've called more than one attorney or two frequently on a daily basis to explain how the rules go here with those with whom we work. And then lastly, risk management is all about sort of just knowing what's going on. This sign you'll see, caution, sign of sharp edges, don't touch the edges, and what's really the important message is at the bottom. Oh, by the way, the bridge is out ahead, so no walking and no driving. Who cares about the sharp edges, folks? It's that message, and it's often what happens here. The bigger picture is what we think is the big risk issue, and it's really something else, and we're going to help you focus on that. So I think that's about all I have, and I'd be more than happy to hear any questions that anybody has, or, yeah.
I have two questions. One is there anything that automatically goes to risk management, like if we should try and we automatically get, no, it's always on, someone has to call you.
Right, so, yeah, no automatic stuff. We are, again, really closely connected with everybody and anybody else who may be in the realm to know. For example, safety, I mentioned, patient care. going somewhere else, a non-academic medical center, you are likely going to have to purchase professional liability insurance. So what you will want to know from the companies that are available to you in the marketplace is what exactly do they have as risk management services? When do they expect to hear from you? When do they reach out to you? Do they have a program of available education or resource materials that you can use? Are there in-house claims handling methods, or is everything outsourced? Because really at the end of the day, you may have questions that you'll want to pose to them, for example, I don't know, maintenance of medical records, but you really want somebody really solid and good when you're in need of claims management. So you'll want to know what their policy is about when do they want to be informed. Early, when you have a bad event, or wait until you get sued and have just the coverage attached at that point. Earlier the better for that. And you'll want to know financially what their ranking is and rating, because again, at the end of the day, you want to ensure if you need to have monies paid, that financially the company's on the up and up and has the money to support that. If you're going to another academic medical center, you're going to want to know what's the culture around disclosure of early op or apology. How are things managed when there's a bad event? Who is the upfront? Is it guest services? Is it quality patient safety? Is it risk management? Who will you likely be working with? And we hope that there be well-suited processes in place for that. Go ahead.
As we are getting in more and more supervisory roles, and let's say something happens with someone that we're training, what's, I've seen it handled differently in different situations. Like some people will take the resident completely out of it, or the fellow completely out of it and handle it. What do you usually recommend, or what's?
We would hope everybody who's got firsthand knowledge and who's involved remains involved, because part of managing this is not just crap hit the fan and now I walk away from it feeling myself like it's a bad circumstance, but helping them work with that. I would expect that in training others, there would be help in how to communicate with patients about it, how to confront those difficult conversations. And again, that's where we think we could be helpful. We also know that it can be stressful and really challenging for those involved. And if there's some assistance that needs to happen, we will recognize that bucking it up and getting back on the horse may not be, for that particular resident, the most appropriate method. That maybe some lightened duties or time back would be helpful. So I don't think there's a one-size-fits-all. We like to think everybody stays involved and remains involved, but you've got to be able to sense what that does to the individual as well.
So, since we're now in point of Packard,
Yeah.
Say we did residency somewhere else, or I'm thinking if it's with residents, they would pay also at Santa Clara Valley, but if you're part of this institution, is it kind of retroactively affect you, or just, or is it covered if you're working at a different site, but you're still employed?
Yeah, so the way the insurance program works is you're insured for everything within the course and scope of your Packard affiliated duties. So if your rotation takes you somewhere else, we probably own you for that purpose as well. We do own you for that purpose as well. If you then switch and become a Santa Clara County, employee, then they would, for purposes, work with you on any go-forward things. But anything that happened up to the point of that, we would remain involved even if you're gone from here. So, for example, you are working here now, and next year you're at UCSF. A lawsuit pops up here that occurred while you were here. We would work with you on that particular matter.
And let's say, but more the other, so let's say you did residency somewhere else, and now I was here, and now all of a sudden there's a lawsuit.
Wherever you did your residency owns you for what happened during the residency period. The nice thing about academic medical centers is they own you for the whole time you were there doing things while you were there. When you come here, year, we owe you, and the really nice thing is there's no gap, it's just who you go to. So we had a call, actually last week, where a resident was calling us, and he was like, I got this subpoena, blah, 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 and he was going through the whole thing, and we were like, okay, who's the plaintiff attorney? And it was a law firm out in New York, and we were like, wait a second, did you do a residency in New York? Yeah, I was at NYU, this happened while I was at NYU. We called the risk manager there, connected the two of them, they ended up going off and not talking about it. Anybody else? I'm thinking it's a gloomy Thursday, time to bolt. So, long story short, again, I apologize for the mixed message there. Know that you shouldn't think too hard about should you